I'm here today to talk about my concerns about the use of physical restraints. I'm most concerned about the lack of common protocols and definitions across these systems throughout the state. Now, physical restraint is when staff physically hold on to a person who is dysregulated if they are harming themselves, harming others, or are destructive to the environment. This intervention is not without risk, as evidenced by a death here in our own state earlier this year. Having worked as a cross-systems advocate and as a peer support for families with children in residential, I've heard the stories from the families, their stories of frustration and pain. And so I really feel that this is a really important topic to look at. Now, when we're looking at across systems, each system has its own regulations and standards for restraints. In OMH and OCFS, staff are trained in something called therapeutic crisis intervention. However, in one of the cottages on the campus where I work, the regulation says that the children need to be restrained face up, whereas on the other cottage, the restraints are face down. In OPWDD, they use the SKIP curriculum for training and for restraints. And state education has only just begun to make recommendations regarding how to safely restrain a child. They use PBIS, the Positive Behavioral Supports and Interventions, as a crisis management technique, but there really isn't any regulation across the board in standardizing the training and the techniques that are used in that system. Each system also has very different reporting criteria, making it very difficult to compare interventions across systems. Especially distressing is the lack of any reporting protocols at all in schools. There's no regulatory requirement for the schools to document restraints, to notify parents, or to collect and report data to state ed like the other systems have to do. We need some common definitions between the systems regarding restraints as well. In some programs, it's you do a restraint if there's a life or limb, if there's a chance that somebody could die or be severely injured. Whereas in other systems, one of the recommendations for the use of restraint is if the person is disruptive to program. And that's a pretty big gap that we need to narrow down. For the sake of safety, we also need to generate some common definition of factors that contraindicate the use of restraints. So things like if somebody has a physical condition like asthma, or conditions that increase the likelihood that a restraint is going to be counter-therapeutic. Like if a person has post-traumatic stress disorder, putting them in a physical hold may exacerbate their condition. So I recommend creating a task force to identify ways to standardize practices regarding restraint and crisis intervention across the state. The task force will measure the progress on recommendations made by the Committee on Restraint and Crisis Intervention Techniques back in 2012. So we'll see how far we've come. But this task force will also compare data across the systems on physical restraints and the injuries that occur as a result to both the individuals and the staff in order to identify common measurement standards for reporting. And this will enable us to track the trends and promote effective crisis intervention and reduce the risk of injury and death. Thank you for your consideration.